There's hardly any audience. Good morning, everybody. Thank you, Dr. Jayeshnan sir and Deepthi of the Scientific Committee for giving me an opportunity to talk about this topic. The topic today is will be confined to 20 minutes, is thromboprophylaxis in gynecology. So I will be just talking only about gynecology and thromboprophylaxis, nothing more, because of the constraint of the time. Venous thromboembolism is a major cause of preventable morbidity and mortality. Thromboprophylaxis reduces but does not eliminate any VT-related events and mortality. So it only decreases. The risk of developing a deep vein thrombosis in the first 3 weeks after gynecology surgery is about 17 to 40%. And most of them happens in the first 6 weeks. Of all the hospital-acquired thrombosis, 50 to 60% are after surgery. Gynecological surgery presents some unique risk factors, and most of the data which we are going to talk are extrapolated from general surgery or from the orthopedic. There is a lack of guidance for the gynecological surgical patients. Now I'm coming back to the old pathophysiology, that is Virchow's triad. You all know 3 factors: the endothelial injury, the stasis, and the hypercoagulability. If you have a surgery or an inflammation, that will produce some changes in the endothelium, which will increase the risk of thrombus. Stasis, immobility, pelvic mass, lithotomy position are stasis. Coming to the hypercoagulability conditions, we can divide that into 2 factors. One is patient-related, and this is procedure-related. In coming to the patient-related factors for hypercoagulability are age, BMI, ethnicity, if the patient is on HRT or patient is on combined oral contraceptive pill, ethnicity, or a history of acute admission to the ward recently with an abdominal inflammatory conditions. And procedure-related, as you all know, the increased length of the stay in the hospital, significantly reduced mobility for some factor, laparotomy compared to laparoscopy or vaginal surgery, procedure complexity like a retroperitoneal node dissection or sigmoid colon resection or radical hysterectomy. So, but when a patient walks into us, we need a system or a scoring system to know whether this patient is highly risk to develop deep vein thrombosis or not. So, Caprioni, in 1991, a physician, devised a scoring system based on multiple risk factors. And that is called the Caprioni risk factor scoring system, and that which still we use for scoring the patient. So this is an example of the Caprioni scoring system. You don't need to go into the detail, but I just want to show that different points are given for different factors. For example, a lady with varicose vein will have 1 score. A lady with a malignancy will have 2 points. A lady with a recent stroke will have 5 points. A lady with a history of DVT may have 3 points. So you put point scoring system for each patient on admission, and then you risk the patient, you categorize the patient into different categories like low risk, moderate, high or highest. But only thing I just want to specify in that if the score is more than 5, they become high or highest. If these 2 categories of patients may need pharmacothromboprophylaxis in addition to mechanical thromboprophylaxis. That's the only thing you need to remember. And that also the dates changes from 10 days to 30 days. So coming to the unique features, what are the reasons? Because in early pregnancy, the thrombin generation increases as early as 5 weeks. So there they have a hypercoagulable state. The risk of venous thromboembolism increases in the first trimester. So women with a previous history of venous thromboembolism or a total score of 4 should be started on pharmacological prophylaxis as soon as admission in the first trimester for any gynecological surgery. I'm not saying any patient needs admission, pharmacotherapy, only patients who goes the score more than 5. And hyperemesis, another common condition. when you vomit, you get dehydrated. Dehydration leads to hemoconcentration, on one factor of the virtues. And you all know if the patient vomits, you become fatigued and you become immobile. So there's a transient risk of developing thrombosis if a lady gets admitted with hyperemesis, so don't ignore it. Ovarian hyperstimulation syndrome, but because of most of the patients with assisted reproductive technique, you know, then ovarian hyperstimulation syndrome, there is hemoconcentration and vascular endothelial dysfunction. Both are procoagulant states. So what happens is, the thrombosis in ovarian hyperstimulation syndrome it happens in unusual sites like upper limbs and also in the arterial system. So, and also it can present about 30 days after the resolution of ovarian hyperstimulation syndrome, that should be aware about. A lady who had an ovarian hyperstimulation syndrome after IVF, compared to a lady who had a pregnancy after IVF, there is a 50 times more chance to develop thrombosis. So when these patients getting admitted, we need to be more vigilant. So there is a miscarriage, there's a risk with paucity of or lack of evidence. So the risk assessment tools should not be used as a term pregnancy because the patient is bleeding. If at all her score is high also, if she is having a miscarriage, if you want to start a pharmacothromboprophylaxis, you should have a multidisciplinary meeting. Because that means basically if the patient had a miscarriage, even if the score is slightly high, she better not to give a pharmacothromboprophylaxis. So you all know cancer is a recognized risk factor, higher risk in the post-operative period, especially women who had laparotomy. But just because of the cancer, but suppose she had a minimally invasive surgery for carcinoma of endometrium, she doesn't need any pharmacothromboprophylaxis. Of the malignancies, epithelial ovarian cancer has found a higher risk of developing thrombosis. In that cases, the DVT prophylaxis may extend up to 4 weeks after the pelvic cancer surgery. Now, coming to the common condition, one is if the patient is taking combined oral contraceptive pill. The risk of developing a thrombus when a woman on combined oral contraceptive pill is still lower than a pregnancy or in the postpartum state. But there is still a risk of about 3 to 15 in 100,000 women. So highest of the chance of developing a thrombus in the first year of their intake of the oral contraceptive pill. And also the highest risk in the first few months. And following this risk reduces and the patients become stabilizers. Hence, not recommended to frequent stopping and restarting is discouraged because of this reason. Because in Kerala, most of the women will take oral contraceptive pill when their husband visits from abroad for a couple of months and again they stop. They are more prone to develop thrombosis compared to patients who are continuously on the pill. So when these patients come to the surgery, when will you stop you have to stop the oral contraceptive pill at least 4 weeks prior to the surgery because there is an increased prothrombic level factors which is brought by the oral contraceptive pill has to come back. It takes 4 to 6 weeks to come down. And they found that a marginally third generation progesterone like gestodin will increase the risk compared to the second generation progesterone. And they also found there's no difference between whether you use pill, ring or patch. You need the same precautions has to be taken. When will you restart the oral contraceptive pill? You have to wait at least 2 weeks until the patient is fully ambulant. Coming to the HRT, there's no need to stop it. That's basically I want to get the message. Transdermal HRT is the safest, and estradiol-associated HRTs are better than conjugated equine estrogen preparation. And estrogen alone preparation is much safer than estrogen progesterone preparation. And overall, the VT risk is not increased by continuing HRT in the perioperative period, and Canadian trials doesn't advise to stop at all. You can continue if the patient is on that. Nowadays, we have a lot of patients with COVID. COVID is an identified risk for developing thrombus. So there's a hypercoagulative factor with it. So better we recommend to, if the patient needs an elective surgery, at least to wait for 3 months if she had a recent COVID infection. The more evidence are evolving. So what is the effects of anesthesia in developing thrombus? General anesthesia produces muscle relaxant. Spinal anesthesia or the regional will produce muscle paralysis. Both leads to the venous stasis and inadequate calf pumping. So the slowing can also produce stasis and also endothelial damage. They develop thrombus. So they found that the regional anesthesia is associated with the lower risk of developing thrombus compared to general anesthesia, and length of surgery. More duration than patient in the theater, more prone to develop thrombus, and mostly if it goes, surgery goes more than 4 hours. Method of surgery. Higher incidence was found in laparotomy compared to laparoscopic hysterectomy in benign condition. You know that when you have a minimally invasive surgery, the patient will have an early ambulation, faster post-operative recovery, and an early discharge. But remember, a very high score in the Caprioni score, laparoscopy still carries a risk of thrombosis, and hence individual assessment should be made. Route of surgery. Vaginal surgeries are found to have a least risk of developing thrombus compared to any other surgery. And even in the urogynecology study also, they found that if they have a vaginal route compared to abdominal route, it's much safer. And longer the duration of the patient staying in the hospital, more risk. Day cases are less prone to develop thrombosis. That basically, longer the duration, higher the risk. So what are the methods? How can we prevent thrombosis? One is ambulation, the second is mechanical, and third is pharmacological. Ambulation means you ambulate the patient, is an accepted method. Ambulation alone should not be considered as adequate, or it is not a reason enough to discontinue the pharmacological procedure. In low-risk procedures like a day case surgery, diagnostic laparoscopy or tubal ligation, only ambulation is recommended by the American College of Obs and Gynae. So two mechanical things, so the graduated compression stocking or anti-embolic stockings or TED stocking. TED stocking stands for thromboembolism deterrent stocking, the same thing. They work by exerting a compression, greatest at the ankle and decreasing upwards, prevent pooling of blood and endothelial injury due to stasis. Recommended ankle pressure is 16. Knee length versus thigh, there are two lengths available, but there's no much difference. Knee length will be enough, and the patient compliance is higher with the knee length. And proper fit is important because the tourniquet, it should not be rolled down, or the tourniquet effect will produce more harm. They found that a 40% reduction in thromboembolism if you just use these stockings. And the mechanical one, you must have seen this machine, is an intermittent pneumatic compression device which prevents peripheral pooling of the blood. It decreases the incidence by 60% and need to use at least for 5 days to have a good effect. If you combine IPC with another low molecular weight heparin, the incidence of DVT can be brought down So what are the contraindications and complications of mechanical? If you have a peripheral arterial disease or a neuropathy or an arterial bypass, a lady had a bypass, better not to use it. Skin condition like dermatitis, leg edema, known allergy to this material, and severe limb deformity, this IPC cannot be used. And skin adverse effects with IPC are, one is forefoot edema or lymph edema, which is layer. Allergy, soft tissue, and nerve damage has been recommended. But the lady, if she's having a congestive cardiac failure, and if you put IPC, the whole fluid from the legs can be pushed up to the heart, and they can produce into cardiac decompensation. Now, coming to the last point, that is the pharmacoprophylaxis. Before we want to start the as a gynecologist, we are worried. If we give an low molecular weight heparin or any anticoagulant, will she bleed? So we need to know the risk factors for the bleeding to be considered before the pharmacological prophylaxis. If you don't start, they may have a thrombus. So there are two patient-related factors, like if the patient has an active bleeding, like you did a myomectomy or a retroperitoneal dissection, you are worried that she is going to bleed, then we can withhold the pharmacotherapy till the bleeding risk is developed. Or does she have an acquired or a inherited bleeding disorder? Concurrent use issue on any other use of other anticoagulant, or an acute stroke, which we don't do any surgery, and an uncontrolled blood pressure, more than 230 to 120, and the platelet count of 75 are contraindications to start pharmacotherapy. Or if the patient is going to have a lumbar puncture, epidural or a spinal in the next 12 hours, or if she had the same lumbar or spinal within the last 4 hours, we should not give a pharmacotherapy. Or any increased bleeding specific to the procedure are contraindications for pharmacotherapy. So what are the things available? One is low molecular weight heparin, you all know, is as effective as unfractionated heparin. Need dose adjustments in renal patient because it is excreted through kidney. It's a preferred agent of choice, once daily dosing and most effective than unfractioned heparin. The low-dose unfractioned heparin is another drug which is used, but not used nowadays because of the availability of low molecular weight heparin like enoxaparin. They found that there is a 47% reduction in odds ratio in developing fatal PE. But only advantage is in the renal impairment patient, you can use unfractioned heparin because it is not excreted through the kidney, but it's not commonly used nowadays. The other new drug is fondaparinux. Gynecologists usually won't use that mostly. We still use enoxaparin. The only thing is the fondaparinux is a synthetic analog of low molecular weight heparin. There's no much advantage. NICE guidelines gives you as an alternative. The disadvantages is a longer duration of action and a lack of reversal agent. Now, the direct oral anticoagulant. So suppose a lady suppose it's a high Caprioni scoring system, and we have done a surgery and she's only for 3 days with the hospital, but she needs another 5 or 6 days of anticoagulant when she goes home to complete the 10-day, or suppose she is a very high risk and she needs 30 days of anticoagulant. Before, we used to send them home with the Clexane. You need to take it for injection every day. So this direct oral anticoagulants are tablets which have a rapid onset of action. It has a short acting and low bleeding risk compared to warfarin. The other advantage doesn't require any regular blood monitoring. There are few drugs like apixaban, dabigatran, rivaroxaban and all. Only apixaban has been, we are using in gynecology, and that's the one recommended. Few studies have come up like comparing the apixaban with the Clexane. They found that patient is more comfortable in taking tablet because it is easy and there's no need for monitoring the drugs. The reversal of the dose of apixaban is 2.5 milligram BD for 10 days or 30 days if the patient needs it. The reversal of anticoagulant in case of bleeding is by antidexan alpha is the antidote, or for apixaban, or prothrombin complex concentrate that is available as a synthetic material. So what are the pharmacological contraindication? If the patient have an active bleeding or any condition of increased bleeding, you cannot give pharmacological contraindications for them. So what are the adverse effects? One is the injection site reaction, the other is thrombocytopenia, and the third is osteoporosis upon the long duration. But injection site reaction and thrombocytopenia are relatively less with low molecular weight heparin compared to unfractionated heparin. Coming to the ethical issues, the low molecular weight heparin is derived from pig. So patients who doesn't want pig products, we may not be able to give it if they become aware of that. Non-comprehensive from our part, because most of the gynecologists, as well because of the fear of bleeding, we usually are reluctant to give anticoagulant in the post-operative period. So non-compliance is a contributory factor in case of venous thromboembolism. And in most of the hospitals, not consistently applied by the clinicians. That's all. Thank you.
Thank you so much, sir, for that very informative presentation. And for the attention of delegates, if you have any queries or doubts regarding the session, you can write it down on the paper and can be handed over to the volunteers who are inside the hall to help and assist you. And all the queries and doubts will be addressed by the faculties at the end of the session. Once again, thanking Dr. Vino Balakrishnan, sir.